The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our Safe and Calm webinar for April 7th. This is Deanna Mitchell from Leading Age Michigan. For more than a week, we've been hearing that mdhhs intends to update some of its guidance specific to visitation, and we kind of thought that we would be discussing that this morning. However, they've yet to issue anything. We've heard that they're not quite comfortable with the more lenient visitation rules, and we're kind of looking forward to see how they will alter those, and if they do alter them, whether they will do that for all facilities or just HFAs and AFCs. If they change it again for nursing homes, we'll again be in conflict with CMS. But we have not gotten any final word about the guidance. We will keep everyone updated as we hear more. Today we're going to start with our advocacy update, and Dalton will be talking about the SNF premium pay rules that came out last Friday, the American Jobs Plan, and the long-term care infrastructure proposals. And today we're going to focus on CDC and CMS guidance for isolation and quarantine, and kind of go through the parameters around that. So we'll now turn the presentation over to Dalton.
Good morning, everyone. So as Deanna said, we're going to start with the premium pay guidance that was released last Friday, and then we'll move into some national issues that I think it would be good to be aware of as they make their way through the political process. So the SNF premium pay guidance was released in L letter 2129. It's linked there if you need it. There have been very few changes for SNFs. I am just going to highlight the actual changes to the guidance here. Generally, the changes include extending the time frame that the program will be running from March 1st to September 30th of this year. They increased the payments from $2 to $2.25. In terms of administration and the changes there, they changed the rate for overtime to reflect the increased rate for the wage pass-through to $3.38 an hour. And then in terms of reporting, they did update their reporting form so it is appropriate. And we did talk about this form last week, and it was pointed out that there was an error on the form that the state had published, and they have since went back and fixed that error. It listed the premium pay being set at $2, but calculated correctly. It now says $2.25 and calculates correctly. And that is attached to our handouts in today's webinar section. So on March 31st, the afternoon of March 31st, President Joe Biden released via the White House his American Jobs Plan, which is his $2 trillion infrastructure plan that he'd like to see move forward. Specifically in the plan, there's $213 billion for housing support. He highlighted a couple of things here. He'd like to preserve, and retrofit more than 1 million affordable housing units. He plans to do this via tax credits, grants, formula funding, and project-based rental assistance type of programs. He'd like to build and rehab more than 500,000 homes for low and middle income individuals. He'd like to eliminate exclusionary zoning and harmful land use policies to promote housing. To do this, he would like to create a grant program with awards that go to jurisdictions that take steps to eliminate barriers to producing affordable housing. He'd like to help housing providers address longstanding public capital projects with a fund of $40 billion. And generally, he'd like to put workers back to work upgrading homes and businesses. He plans to do this through a block grant program, the weatherization assistance program, and home and commercial efficiency tax credits. So just a large overview summary of what's in there for housing providers, and stay tuned on this as it makes its way through the political discussions in Washington. Leading Age National also released their own long-term care infrastructure plan. They have submitted a letter to the White House highlighting a couple of things. They titled it The Blueprint for a Better Aging Infrastructure, so you can click right there to read it for yourself. There's a lot of details in this, but I just wanted to provide a summary for you today. They call for additional funding for the entire aging services continuum through a variety of mechanisms, which you can find in the plan. They'd like to offer a number of policy solutions that they think would help address staffing issues across the nation. They'd like to expand and formalize some of the access and processes relating to home and community-based services and housing. They're looking for long-term care financing reform, and they'd like to have some of those resources go to the modernization of SNFs and other congregate living settings, and then, of course, ensure a comeback that is appropriate from COVID for long-term care providers. Just another shout out here in case you're still interested. Leading Age National is having their National Advocacy Day virtually this year, and it gives everyone an opportunity to advocate on behalf of those you serve with their national representation, and it's completely free for Leading Age members. You can click that link there to register if you'd like. There's still time. The actual event will take place on April 21st. It will run from 9 a.m. to 4:30 p.m., but really what will happen is we'll have a couple of meetings scheduled as a state during that time frame, so it won't be a constant 9 a.m. to 4:30. It'll be 30 minutes here, 40 minutes there, that kind of a thing. April 14th will be the preparation day that Leading Age is going to host virtually. They'll give a high-level overview of their advocacy platform and discuss some ways and some tactics to discuss these issues with your national representation. And then after the 14th, we will schedule a call with all those registered just to kind of coordinate schedules so that we don't have a bunch of people going to one meeting and no one going to another one, just so we can have all our bases covered. And with that, I think that's the end of my presentation for today. Pretty quick and overview-ish today.
All right, thank you very much, Dalton. Before we get into any questions, just have a couple announcements I would like to make. The first is the Michigan Department of Health and Human Services is hosting a meeting this morning to give an update on coronavirus trends in the state. Dr. Sarah Lyon-Callow, the director of the Bureau of Epidemiology and Population Health at mdhhs, will give information about testing, disease trends, outbreaks, hospitalizations, deaths, vaccinations, and trajectory of the virus in Michigan. The brief is scheduled for right after this webinar, basically. So the brief is scheduled for 11:15 a.m. and it will be streamed live on woodtv.com if you are interested in watching that. Additionally, I will go ahead and pull up our website again. If you are interested, you can go ahead and click on this events tab here. And we have our SNF Regulatory Day coming up next Wednesday. So I guess that gives you a reminder that we will not be hosting a Safe and Calm webinar next Wednesday. Instead, we will be having our SNF Regulatory Day. So if you are interested, you can go ahead and register there. We also have our Housing Matters program coming up at the end of this month on the 29th. Registration is open for that. And we have our Assisted Living Conference. It used to be called ALHFA Day if you are interested in that. And that will be Thursday, May 6th. Registration open for that as well. So with that, I actually do not see any questions for you, Dalton. So we will go ahead and move forward.
Okay, thanks, Blake and Dalton. We're going to take a quick look at the data for Michigan. And right now, unfortunately, Michigan actually leads the nation in cases, hospitalizations, and in county positivity rates. The case rate has increased dramatically from last week. And the death rate is slowly creeping up, although at a far less rate than usual, and certainly not in direct relationship to the number of positive cases. So we want to take a moment and note that MDHHS here in Michigan has reported a number of new COVID cases for persons who were actually fully vaccinated. There were 246 persons diagnosed with the virus total that they're aware of course. And the percentage of persons officially diagnosed is very small, really, and within the range of vaccine effectiveness. But it does underline the reality that the vaccine will not protect everyone from the disease 100% of the time, though it does continue to really support the idea that it's a very effective vaccine. Here's the CDC Case Rate Map, and you can see high rates in Michigan along with a handful of other states, and that the average daily rate per 100,000 persons, as documented by the CDC, was 452 for Michigan compared to 133 for the entire country. So that's a significant difference, and cases are definitely on the rise here. The number of cases that are diagnosed as related to a variant also continues to grow in the state. We continue to be second only to Florida in overall numbers, specifically for B117. I think there's 3 ones in there and I missed one. But the number of variants is obviously growing in other states as well. It used to be only Florida and Michigan were in the dark blue category, but we can see growth of the variants everywhere. Here's our standard 7-day rolling average of new cases for Michigan, and you can really see that there's a steep incline, and that incline is almost approaching the December surge numbers. So this is something I know that the governor continues to watch and is looking at. Comparatively, if you look at that second very high peak, that's the case rate in December. Comparatively, the death rate isn't climbing anywhere near toward that, but we do see not only the kind of up and down weekly trends, but also a definite incline. But again, not anywhere near as high as the caseloads rising. Looking at the CMS positivity rates, you can see that the caseload numbers are reflected here, causing a marked increase over the past week in the number of counties in the red category. Remember that that category means that the positivity rate in a county is greater than 10%. And that also means that nursing homes will have to do twice weekly testing in those regions for staff. Skilled nursing saw a slight increase in the number of new resident cases, but overall it still seems pretty stable. The same is true for HFAs and actually AFCs when we get to that slide, although the increase was a little bit higher in both of those provider types. Looking at all of the long-term care numbers, you can see that there continues to be more cases for staff, and we would expect that since they have a much lower vaccination rate, and hopefully that will change. Total long-term care resident and staff cases are now heading toward 46,000. So today we're going to look at the CDC guidance and some information from CMS as needed. And we're going to include the rules for isolation. The rules for isolation are pretty straightforward. The rules for quarantine, they keep changing, and they have changed a lot. And there's been a lot of confusion around some of that guidance. So we're going to look at that again today. So we're going to start with the latest CDC guidance from 3/29. And that's the guidance that was created by combining 2 earlier CDC web guide pages. And it did clarify some of the requirements for isolation and quarantine. Obviously, again, the isolation part is easy. You must isolate and place anyone with positive testing in a designated COVID-19 care unit whenever possible. The I'm sorry, go back, yes. The latest guidance pretty much also restates the requirement to place all admissions and readmissions in a 14-day quarantine, regardless of testing. So that blanket statement has been confusing to a few people because we know that there's been other guidance that says something else. But those exceptions are noted here, and we'll go through that. The first exception includes residents who are within that 90-day recovery period. And we do know that they do not have to be quarantined on admission. Another thing that we want to note is that the CDC guidelines clearly state that facilities in areas with minimal to no community transition might elect to use a different kind of approach, basically symptoms and test-based, determine which residents need to be quarantined on admission. But we want to clearly state that mdhhs does not allow that. The caveat here that's most important is that the second bullet that says all other new admissions and readmissions should be placed in 14-day quarantine. The last bullet will tell you, unless noted in the updated healthcare infection prevention and control recommendations, and that is a 3/10, a March 10th update. So this guidance applies regardless of vaccination status and level of vaccination coverage in the facility, except for what is in the March 10 guidance. And we're going to go to the next slide, which tells you that right here. So the rule still applies that quarantine is no longer recommended for residents who are being admitted to a post-acute care facility if they're fully vaccinated and have not had prolonged close contacts with someone who was infected in the prior 14 days. So that rule still applies. For residents who leave the facility, this has not changed much. Residents and families should be fully aware of risks and the safety precautions they need to take whenever they're leaving the facility. If they leave for less than 24 hours, quarantine is not recommended, although facilities are really expected to screen the resident for risk and make an individual determination. So if it looks like there's some question about how they managed risk while they were outside of the facility, you can choose to quarantine them. Residents who leave for 24 hours or more should generally be placed in quarantine. But note that they're referring here to treating these persons just like the rules for a new admission. And what that means is if they are fully vaccinated and have had no close contacts, they do not need to be quarantined on return to the facility either. In general, residents with close contacts should be placed in quarantine. And anyone in quarantine must be treated with transmission-based precautions, and that includes eye shields and N95 masks. All that continues to be required. They can be placed in an observation area or a single room. If there are a lot of potential cases, such as in an affected area during an outbreak, they can shelter in place while being tested and monitored. And this quarantine, of course, has to continue for 14 days. And hopefully they will not have symptoms at that time. Remember that the state does not allow alternatives to these rules. There are alternatives noted in the CDC guidance, but mdhhs and local health departments will not allow them in terms of quarantine time. This next section is about guidance for persons who are actually suspected or who have actually developed a confirmed COVID infection. Again, full PPE, including an N95 or higher respirator is needed. They should be moved to a single room with a private bath at the bare minimum. However, cohorting is preferred, as it has long been. The new guidance talks a little bit more about doors. That's been an issue, we know. Doors should be closed for anyone with either suspected or confirmed COVID. And it's especially true when they're not being cared for within a COVID dedicated unit. If doors absolutely have to be open for resident safety, such as someone with significant dementia, they suggest that the facility take action to minimize any airflow into the hallway. So you're going to have to look at that. Again, if there are a lot of persons who are suspected of having COVID, you can shelter in place until testing is completed. But the roommates of positive persons should be considered highly potentially exposed, potentially infected, and they should be placed in a single room if possible and quarantined. And of course, in an outbreak, you must increase monitoring to 3 times daily when residents are confirmed or suspected, at least for an affected unit. The link to this guidance is at the bottom of the page. So when you actually have a confirmed new infection, that of course will trigger an outbreak. Whenever there's a new staff infection of any type where the staff member's been in the facility during the infectious period, or any facility-acquired resident infection. Either one of those scenarios will trigger an outbreak. At the first signs of an outbreak, it's recommended to increase monitoring of all residents to every shift until you identify the extent of the outbreak. So facilities need to start facility-wide testing. They need to use full PPE for all residents until the extent of the outbreak is known. Residents should be restricted to their rooms during this time. Consider canceling all communal activities until you can identify that the outbreak is localized. Again, and I think this is new language, I think it makes sense, but I don't remember seeing it before, that during such a time when you've had an outbreak and you're evaluating it, you should restrict any non-essential staff and offer non-essential healthcare professionals, let's say that, and offer telehealth as needed in lieu of that, whenever possible. The CDC recommends testing everyone 3 to 7 days, but they actually suggest that you test everyone every 3 days for the first 2 weeks, because their belief is that the quicker you understand the extent of the outbreak, the better it'll flow. But you must conduct testing of all residents and staff at least weekly, again, until at least 14 days following the last positive case. Okay, following infections, post-infection, no changes have been made to guidance for persons who are within the 90-day recovery period, although the CDC does identify that certain circumstances would make testing and quarantine needed, even though a person might be within that 90-day period. So we've all known that immunocompromising conditions, they often extend the infection in certain persons, and so that would be an exception. If there was any consideration that the infection was diagnosed through a false positive, such as if the resident was asymptomatic and only had a positive antigen test with no confirmatory test, then if something happens, they have a close contact, you should probably consider them as potentially exposed and potentially infected. And this next part is new. The 90-day recovery period doesn't apply if the positive result was due to a variant. Now, we do know that it's not always known whether or not the test was due to a variant, but we believe that the lab, and you can only know that through PCR testing, the lab will let you know that it's a variant when they do any tests, and the local health department as well. So CDC updates to quarantine guidance for staff were made and updated again after that, but basically on 3/11. Asymptomatic staff who are fully vaccinated and have a higher risk of exposure do not need to be restricted from work. Although there are a few exceptions, and again, immunosuppressed persons would apply there. Note that fully vaccinated means fully vaccinated. If you're partially vaccinated or for some reason haven't completed the full period after of 2 weeks following your last scheduled vaccination, you are not fully vaccinated and the normal rules apply. They do identify travel as a necessary travel guidance for staff. They allude to it here. We're going to talk about the updated travel guidance and the quarantines related to that a little bit later today. High-risk exposures tend to involve exposure of the eyes, nose, or mouth to potentially infected material. And again, if these occur under normal circumstances within a 90-day recovery period, no work restrictions may be necessary at all. So here's the updated table that includes guidance for staff exposures. Note that these recommendations are intended only for exposures that occur within healthcare settings. So staff with prolonged exposure who may be immunocompromised or were not fully vaccinated or were not fully protected, and there are some bullet points there that identify how they might not be protected. If any of those scenarios are true, you must exclude the staff from work for 14 days, have them self-monitor, and of course notify you if any symptoms develop. Staff with any other healthcare-related exposures, in other words, not quite as high risk, etc., there are no work restrictions, but they are reminded to follow all safety precautions and monitoring for any kind of symptom development. So if staff have traveled and become exposed and developed they're under suspicion for COVID or they have confirmed COVID, obviously they will have to quarantine and no travel until the quarantine period is over. So if they're in the middle of travel, they're not supposed to travel back home if they've identified a positive case or if they've had a significant exposure. If they are fully vaccinated and exposed, there should be viral testing 3 to 5 days after travel, but there's no real need to quarantine them. If they're not fully vaccinated and they are not within that 90-day recovery window, again, testing at 3 to 5 days after return, along with a 7-day period of staying at home, and that actually extends to a 10-day stay at home if no testing is done. And of course, if the staff is in that 90-day recovery window, no testing or quarantine is needed. So the table we just looked at were for people who had exposures and suspicion of COVID. For staff that's traveling with no known exposures, if they're fully vaccinated and they're traveling domestically, there's no testing required, there's no quarantine required. International travelers, though, first of all, they have to adhere to any rules about specific regions that they might be traveling to that might have high rates of transmission. Otherwise, it's recommended that they be tested within 3 to 5 days of return, but no quarantine, but only if they've been fully vaccinated. If persons have not been fully vaccinated and they're not within that 90-day recovery window, they should be tested before travel and within 3 to 5 days following travel. They must stay home for 7 days again, and that's extended to 10 days if no testing is done. And at the same time, all contact with persons who have high risk should be avoided. And that's an important piece here. So if they're not fully vaccinated and they need to be quarantined, and all contact with persons with high risk should be avoided. Again, if in the 90-day window, no actions are needed. So Leading Age National put out a summary of these new travel updates. And basically, if a person's only partially vaccinated, again, the flexibilities here do not apply. You have to treat them as unvaccinated persons. Fully vaccinated persons in general do not need to be restricted from work. And residents who are fully vaccinated do not need to be quarantined on return to the facility. All required monitoring, staff are required to self-monitor following travel. But if they're unvaccinated, they should be testing 1 to 3 days prior to any travel, another 3 to 5 days following that, with self-quarantine for 7 days. So Leading Age interpretation of this guidance is that if persons as staff are unvaccinated and they're traveling, they're not allowed to be around persons at high risk. So they have to be quarantined for a minimum of 7 days if tested, extended to 10 days if not tested, but they're not allowed to go back to the nursing home for work for 14 days because they could potentially have been exposed. And unvaccinated residents, of course, need to quarantine for 14 days. So we're going to pause for questions.
All right, thank you, Deanna. I do have a list here, so I'm just going to get right into those. I'm wondering if there is anything significant in the Appendix Z update other than LTC keeps doing everything annually. I don't know if it's supposed to be annually or manually.
I'm sorry, you'll have to repeat that. I didn't really get it at all.
Okay. I'm wondering if there is anything significant in the Appendix Z update other than LTC keeps doing everything and then either annually or manually.
Okay, Appendix Z is the emergency response planning piece. We have reviewed that, but only briefly. I think that if we want to talk about Appendix Z, we can do it another time. And I can respond to this outside of the call, but it isn't necessarily related to our COVID update.
Okay. Can you please clarify if we have a staff member who tests positive, but it was not a facility onset case contracted from a family member, and all other staff test negative, does this still trigger testing of residents?
The trick about a staff case, if I understand the question correctly, is whether or not that person's had any contact within 2 days before symptoms or the positive test and following that. It isn't whether or not they got the infection inside the facility or outside the facility. Any staff person who has had contact 2 days before either the positive test or the symptom development, that's an outbreak, because you don't know where that person's been and who they might have. Well, you eventually would know that, but you don't know that there haven't been close exposures in your facility. So the trick about facility acquired is that facility acquired really only pertains to residents. Any staff person who's been in your facility who tests positive during that time period I just discussed will trigger an outbreak.
If a resident is not vaccinated and is out less than 24 hours and your facility is not allowing visitors due to an exposure, do we keep them in quarantine?
I think that it would depend on whether or not, I'm assuming they're not in the affected unit, because we would definitely be discouraging any people moving out of an affected unit, although you can't technically and legally hold anybody in your facility. So if they're in the non-affected unit, I would think I'd have to look at the individual situation. I would think you would have to do all of the normal things, look at their contacts, etc. But if they're not in contact with anyone either in your facility or who, you know, would be positive, and you're screening for outside of the facility, their experience, I think that you don't have to put them in quarantine. I think you'd have to look at the situation and see if there's risk. If you decide there's risk, you certainly could and should.
The new infection slide says to increase monitoring to every shift, but the slide before that, you said they have to be monitored 3 times a day. Can you clarify? We run 2 12-hour shifts.
Well, I actually noted that myself when I read it, and those were the exact words that came out of different sections of the CDC guidance. I think the CDC guidance is really anticipating that everyone has 3 shifts. So I think the minimum expectation is 3 times a day. If you have 2 shifts a day, it still should be 3 times a day.
Okay. If we have unvaccinated staff member who reports that they are a close contact to a positive COVID case, do we need to remove them from work and have them quarantined for 14 days? How do we validate these reports of them having a close contact in a community setting? This is a big concern as staffing is already at a critical level.
Well, I think that there'd be an awfully high risk in not taking the staff's word for a close contact. I think it would always be a good idea to contact your local health department and talk to them about that. Even though, you know, there's vaccinations among the residents at this point, the guidance still says that you have to quarantine or not allow to work any unvaccinated person with a close contact. And I don't know how you could avoid not taking their word for it. And actually, if you think about contact tracing, you know, notifying the local health department to help you with contact tracing might not be a bad idea.
If 90-day recovery period doesn't apply to variant, what is the timeline?
You treat them as if they were just like anyone else. There is no timeline. So if they were found to be positive with a variant other than B1117, you consider them just like anybody else.
We had 2 staff members who were positive. Should we be testing our residents every 3 days?
My feeling and belief in CDC's best practice recommendation is to test everyone every 3 days for 2 weeks. During that time, you'll get the extent of your outbreak. And then after that, you can go to every week until you've gone 14 days without any positive tests. That allows you to not wait a whole 7 days to figure out that you have a growing problem in your facility. And so it allows you to get your arms around it. So that would be the recommendation. However, you are only absolutely required to do testing 7 days.
For staff travel, there used to be a 3-month limit on fully vaccinated staff. Has this time period been extended or lifted?
I will have to look that up. I do not remember seeing that in any of the new guidance.
Please.
Also, excuse me, Blake. Now, that being said, I do note that generally they were using a 3-month rule, but I have seen recent CDC guidance that says that pretty much vaccinations have been known to be effective for 6 months. So it might be that they're reconsidering and changing that, but I did not see that limitation in any of the current guidance recently.
Please clarify on staff travel with no exposure. The non-vaccinated that have to quarantine, is that for international travel only?
Let's go back to that slide. I don't think so, but I have not committed the not fully vaccinated and not within the 90-day recovering. Those are people who have had exposure. So go to the next one, please. Not fully test 1 to 3 days, 7-day period of staying at home, 10 days of no testing done. Yes, so if they're not fully vaccinated, they have to have a minimum of a 7-day period of staying at home. And as long as they've been tested in 3 to 5 days, if no testing, they're quarantined for 10 days. And that is for any travel, any travel.
What is the definition of travel? Does this mean out of state, out of their town, or just international?
Well, there is no definition for anything other than domestic travel that I saw. I can look up the definition of domestic travel. My thinking would be that if someone's going from one town to another for less than a day, I mean, I think that the travel has to be extended a little bit beyond that. Obviously, we all live in areas where there's adjacent towns to us. I wouldn't consider that travel. I will look and see if the CDC has a definition for domestic travel, and we'll go with that. But I think it has to be beyond, a certain time limit in a certain area. But it is not just international.
So an unvaccinated staff member who leaves Michigan must quarantine for 14 days. Anyone leaving Michigan is going to a lesser area of positivity. Can we use the CDC guidance for crisis staffing or staffing mitigation and let them work? We will not have enough staff if we make everyone unvaccinated stay home after travel.
Go back to that other slide again, please, where we just were on Blake. First of all, it's not 14 days. It's 7 days and then 10 days of no testing. That's the first thing if they're not fully vaccinated. And I do understand the fact that the community transmission right now in Michigan is higher than pretty much anywhere else. However, crisis staffing is dependent on your actual status in terms of your ability to staff. So if you are struggling with staffing, yes, I would go to the crisis strategies, but I don't think that you can just do it because it works for you better. You have to actually be in a crisis mode to use crisis level staffing. And remember, there's contingency levels as well.
What does mdhhs state about these travel restrictions? CDC does not regulate sniff.
Well, first of all, the CDC does not regulate sniff, but they are a nationally known authority on infection control. The CMS relies on them, so you do have to look at that. You even though they don't regulate sniff, everyone is relying on the CDC, especially right now. I could not find anything that talked about travel, and I don't think Michigan has any travel rules that I could find on paper. So that is something that we can try and find out more about, but to date, we've not gotten any, we've asked off and on in the last year about travel restrictions, and we're not aware of any other than what the CDC might have. CDC often has specific restrictions for specific countries. To my knowledge, they've never had any state-to-state restrictions except at the very beginning.
have a staff member that went on vacation April 2nd and has not returned yet, so these new guidelines pertain to them when they return. Staff member is unvaccinated and went out of state.
Yes, I would say these should apply to them.
Okay. Travel restrictions for staff are not realistic for appropriately staffing care of residents. Can the CDC directives for crisis staffing be used in the case of travel? Having employees who travel not work for 14 days makes no sense when employees who are not traveling may engage in even more COVID risky situations. Traveling outside of Michigan could actually be lower risk than staying in Michigan at this time.
Right. I think this is the same question or comment that we had before. And believe me, I do understand the dilemma. I do. I am just kind of repeating to you the rules. It is possible for you to develop travel restrictions. I think that you should, as you develop your policies, you have to rely pretty much on some expertise. CMS usually requires that it be a nationally known authority. As long as you do that, you're fine. If you can find another authority, if CMS says something, then that works. But you do have to have some policies that protect the residents and other staff and consider that. So everything that CDC says is a recommendation, but some of these recommendations are required because CMS refers to them, number one, mdhhs may refer to them, and you do have to rely on a nationally known expert for these kinds of policies.
If a county is above 10% for positivity, do HFAs also need to test twice a week?
No, only SNFs.
We have a lot of staff on vacation right now who are not vaccinated. We will not have enough staff to work. Sadly, we could go from one side of the state to the other in a matter of a couple hours and be in an area with 3 times higher rates.
Well, I think that, you have to look at every individual situation. And if you're going into crisis mode, you take specific precautions and develop a policy for that. I think that you're going to have to make it work in some way. I'm just telling you that these are the rules that have been identified by the CDC. They're not going to work very well. One thing is that I was hoping, at least, and this might be.
Are you still there, Deanna? Sounds like you got cut out. All right, sorry about that, folks. Just give us 1 second. I believe Deanna's call may have dropped, so I'm sure she will be connecting back in here shortly. Well, I guess while we wait for Deanna to connect back in, I will also give everybody a reminder. Let me go ahead and pull it up. On our website, if you would like to, you can go in and go ahead into the sign in there at the very top right. And let me grab my password here. And Dalton, Deanna looked like she chatted in in the thing. Can you answer her while I go over this? I'm sorry, everybody. So while you are, once you sign in, if you would like, you can go in and once you have signed in, you can go ahead and change your profile picture if you would like to do that. You can also go to manage your profile and you should be able to see any invoices. If you have any invoices that needed to be paid, if you want to edit your bio, you can do that. All of your CEs, if you've ever done any type of education with us, you can go in and click on this professional development right here, and that will take you to all of your certificates, anything that you have done. If you need to print those out, you should be all set. You can also go ahead and add your resume if you'd like, and you can get pretty much as personal as you would like. And then also, again, just a quick reminder that we do have multiple programs coming up, so feel free to register for those whenever you can. It looks like Deanna may be back with us now. I don't know. Can you hear me, Deanna? It looks like she's talking, but I cannot hear her. Oh, I'm sorry. I said that. All right. Dalton, what do you think we do here?
Is there a way for you to make me an organizer?
I can do that.
We have her in the chat, so that's good. And we can always, we can't get this, we can save everyone's time, and then we can just answer the questions in written form.
That was my thought as well.
We'll give it a couple more minutes, though.
Please enter your access code followed by.
We can hear
we can hear you, Deanna. I don't know what just happened, but I could hear that.
To enable audio control, please enter your audio PIN followed.
Hi, this is Deanna. Can you hear me now?
Yes.
It sounds like you may have like two things. Oh, try speaking now.
Can you hear me now?
Yep, there we go.
Perfect.
Okay, I'm sorry. I don't know what happened. My phone died. Okay, so we are done with questions, I assume?
We had just, I think, one or two more.
Okay, well, go ahead.
Yep. So this one says not fully vaccinated has the 7-day and 10-day guidance, but it also says after travel, they should not be around anyone high risk for 14 days, which is our residents.
Exactly. And that is, if not fully vaccinated, that is the understanding of leading age. It doesn't say that specifically in the guidance, but leading age recommendation is that it should be for 14 days for residents. So I think I wasn't clear about that earlier.
Slide 32 says CDC recommends 14 days quarantine after travel for those at high risk, which are...
That's the same thing,
the same
right?
thing, yep. All right. So with that, we can go ahead and move forward.
Okay. All right. So last week, actually, I think it was early. It was Monday. We saw that mdhhs through their MyHand transmissions updated guidance to local health departments, and it was called I think their standard operating procedures or something. And at first, to be honest with you, I ignored this completely because it didn't technically pertain to facilities, and it was really meant for local health departments. But we got several questions about it because it was somewhat confusing in the text, in the body of the email. It said they're removing the option of a 10-day quarantine for non-variant cases. And as a reminder, testing out a quarantine strategy has never been adopted in the state of Michigan. So we did send out a link to this with the idea that we would review it. However, we're not going to review this in detail today. It is very confusing to read. We believe in general it aligns with the CMS rules, except for those pieces that we know already that mdhhs isn't going to do, and we've discussed those already. So we're not going to talk about the guidance itself in terms of quarantine today. But if you move to the next slide, there were some pieces in this that I thought was interesting that we could talk about. And specific to quarantine, which is our topic for today. So one of the things was antigen testing in quarantine. So the local health departments, this is the update to them from the state, if a person tested positive using an antigen test only, and they were symptomatic, you could consider that a positive. So if later on, within their 90-day post-recovery period, they have a close contact, you don't need to quarantine them because they should have some natural, not natural, but immunity from being positive, even though they've had no confirmatory test. But if they were positive without symptoms, the state considers that a possible false positive. If there's no PCR confirming it, they're not exempt from quarantine. Antigen positives, regardless of symptoms, if the PCR is positive, you can consider them immune for 90 days and exempt them from quarantine. And antigen positive PCR negative, you should consider them potentially able to be infected because, again, that could be an antigen false positive. Another piece from this guidance is that a reminder that in alignment with the CDC, all vaccinated residents need to quarantine after any exposures. The CDC does allow some waivers of this under special circumstances, but any decision about that need to be made in consultation with the state or local health department. This is an important piece, I think. Persons who are not residents in a nursing home, so we're not talking about nursing home residents at all here. And if they're fully vaccinated, they don't have to quarantine if the contact was with the B.1.1.17 variant. But remember that all nursing home residents must quarantine if exposed. But others who are fully vaccinated do not have to quarantine unless the test is positive for any of the other variants, which are considered more dangerous. Lastly, this week, the state has now changed its priority list for vaccines and vaccinations to include all Michigan residents age 16 and older. Resources for obtaining the vaccine are listed on this slide. So just for information, help with staff. We are at the end of our presentation for today. Are there any other final questions?
At this point, I do not see any other questions. So we just wanted to thank both Deanna and Dalton for all the information today. And as always, if you do have any questions after this webinar has concluded, you can email Safe and Calm, Dalton, or Deanna at leadingagemi.org, and we will make sure to get those questions answered for you. Again, this is just a quick reminder that we will not be holding our Safe and Calm webinar next Wednesday, as we will be hosting our SNF Regulatory Day. So if you'd like, you can go ahead and register for that. And sorry about the technical difficulties there today. Obviously, everyone has endured those with everything going on the past year. So now with that, I think we will conclude the webinar. I hope everyone has a great remainder of their Wednesday, and we will see you all next time.
Not to forget that there's an 11:15 mdhhs update call. Just let everyone know.
Thank you.
Have a good day.